Hi, everybody. Thank you so much for introducing me and having me, Nancy. My name is Nicole. I'm calling to you guys in on Zoom from New York City currently. That's where I live and that's where I'm working right now. I'm a speech language pathologist, and I'm going to go into a little bit more about the topic that we're going over and kind of how I got here connected with Gladney. So let me just share my slides first so I can do that with you. So let's go to here and then type in the chat if you have any difficulty viewing what I'm seeing right now. Can someone just confirm in the chat to make sure that they're able to see the slides that I'm doing? Okay, thanks for those who answered. Yes, you can see. Okay, so today we're talking about trauma-informed care and specifically how it relates to picky eating and challenging mealtime behaviors. And my credentials are a certified speech language pathologist. And then something unique about me is that recently I received my trauma-informed certificate through a specific website, which I'm going to share on this next slide with you. But I really wanted to combine my interest in feeding and swallowing, combined with my knowledge of trauma-informed care. I really enjoy educating other professionals as well as families and caregivers. So that's kind of how this presentation came about. To give you a little bit of background about me, I've been a speech language pathologist for approximately 5 years now. Since graduating, I've worked in birth to 3. Here it's called early intervention in the state of New York. I've also worked in an inpatient rehabilitation hospital, an acute care children's hospital, a level 3 and a level 4 neonatal intensive care unit. So since graduating, I've exclusively worked with pediatrics, and it's really something that I love and enjoy doing. I find it really rewarding not only to help children, but also eating and feeding is such a big part of everyone's family lives that I also get to really work hands-on with caregivers and family members as well. And then for those of you who have the slides and that you're going to be getting them, I just wanted to write the program that I got my trauma-informed care certificate from, in case any of you are interested. So there's, I think, a variety of universities around the country where you could take courses for it. I went through an online certification program that was a span of, I think, 3 to 4 months at that time. It was all online. It was a combination of modules, and then you would have to respond to prompts, and there were monthly guidance calls. So it was pretty intensive, but I think it was definitely worth it. It changed how I looked at care with my patients and the way I practice. So in case anyone's interested, this is the name, the Caring Essentials Collaborative, of where I got mine, in case you want to look up later. Okay, so the contents of this presentation. So first, we're going to be going into the definition of trauma and what exactly it means for someone to be trauma-informed and provide trauma-informed care. We'll go into the mealtime experience and what that includes for families, some challenging behaviors that you may see as a parent caregiver or as a professional working with families in the home or clinic setting. And then lastly, some tips that I can provide you from my perspective of how to promote happy mealtimes. Okay, so let's first start by going over trauma and trauma-informed care. There are many different definitions of trauma. Some are more encompassing and have longer definitions than others. This is my personal favorite for a definition of trauma. It's by Bessel van der Kolk. He's a famous author and psychiatrist. For those of you who may have a background in trauma, he actually wrote the book when The Body Keeps Score, which is his personal accounts of working with individuals with trauma and him describing how he was able to work with his patients through their trauma. So his definition that he uses is trauma is when your reality is not seen or known. So this may seem like a simple definition, But if you think of maybe patients that you have, of someone you know with a trauma, or maybe own personal trauma, this definition is actually quite comprehensive. So if we think about something that's not seen or known, it's really validating that trauma still exists, even if it's invisible to others. And personally and professionally, I find that more often than not, it is not seen by other people. People don't know what's traumatic for us unless we either tell them or maybe they see a reaction repeatedly in response to something. So if we're taking, for example, physical abuse, right? If we're thinking of a patient maybe who was physically abused, something you could see are the scars, the injuries on that individual. However, it's important to remember that after a hospitalization is done, after that patient's physical scars go away, there are still those invisible scars, those emotional scars, those traumatic feelings if put in similar situations again. So that's why I really like the specific definition that accounts for when your reality is not seen or known. Okay, so trauma has been studied extensively, which is great for us as clinicians and practitioners, that we know now that trauma does have effects on the brain and it can have long-term effects on our body. So here I just highlighted 3 specific effects that it has on the brain. So trauma can affect brain connectivity, and in the long-term run, that could lead to someone having more of a severe course of depression compared to someone possibly without trauma. It can also create changes in specific patterns that are impacted by threat and mediated by cortisol, as that could lead to, as an adult, how we react with stress and what our behaviors are in return to a threat. Lastly, I found this interesting that trauma can impact our immune function. And that means that in the long-term outcomes, because of either repeated stress, long-term trauma, trauma that goes unrecognized, unresolved without expert guidance and help, it could result later on in reduced appetite, fatigue, mood changes, and actually poor cognitive function. Okay. So when thinking about trauma and we're thinking about how someone may experience trauma, where did those experiences come from? I want to first reflect back on adverse childhood experiences, otherwise known as ACE, ACE. And this was studied back in 1998. There are 10 factors that this group highlighted that they think are adverse childhood experiences that have more of a potential to lead to trauma and long-lasting health issues as an adult. So just to review these, I know some of you, my audience, might know them, but to go through, we have first physical abuse, sexual abuse, emotional abuse, physical neglect, emotional neglect, if a child has a parent that was treated violently, if a child has a family member with an addiction to substance or substances, if a child has a mentally ill parent, if a child experiences parent separation or parent divorce, and lastly, if a child grew up in a household where there maybe have been an incarcerated family member. All of these are individually considered adverse childhood experiences. And the idea is that the more of these experiences that a child acquires in their childhood, or the more that they've dealt with, the more that they're set up to have more detrimental health effects as they grow older, and more trauma experiences that keep on building as well. So I'm going to go into the next slide about some statistics regarding these ACEs. If we looked at that list, and maybe even you all as the audience looking at that and thinking about your own childhood experiences, it's not uncommon for us as adults to have experienced one of these, But more often than not, if we look at the statistics that I have here on this slide, it actually says from a 2019 study that they found that 1 in 6 adults experienced 4 or more of these adverse childhood experiences, which is a lot because on the last slide, there's 10. So if 1 in 6 adults experience 4, that's at least 40%. Then if we think about long-term impacts of how I was saying that this isn't really just facts that we state about our childhood background, it really can shape our future in the long run regarding our health. Studies have seen that at least 5 out of the top 10 leading causes of death are associated with adverse childhood experiences. And then the last important statistic that I wanted to highlight was that it has been seen that there could be 44% potential decrease in reducing depression if these adverse childhood experiences were addressed prior to adulthood. So when looking at that list, it's really important as professionals to ask those questions about a child's backgrounds. And I know with Gladney, we're talking more about parents or caregivers to foster children or adoptive children. So it's really crucial to our interview to understand what the child's history was before that child was now put into this new home, because there could have been adverse childhood experiences that that child could have before coming to this new house. And it would be good to know what supports need to be in place before entering this new home and what support they have gotten already. And if they haven't gotten support for those adverse childhood experiences, to figure out how those can be implemented now. Okay. And toxic stress can lead to potentially permanent changes in learning, behavior, and physiology. So stress isn't just something that happens in the moment of a threat or in the moment of a traumatic event. Stress can be always underlying. It could just be something that's bubbling in the background and then not triggered until something specifically occurs. But just having that underlying stress constantly can lead to detrimental effects as a child gets older. So I like this pyramid image. It's a way to outline what I'm saying about the building up of stress, the building up of trauma, and kind of more to show how those statistics about adverse childhood experiences, how they can result in those leading causes of death. It's not just a direct relationship between I had a child who experienced separation of their parents, so that automatically means that the child is going to have an earlier death. That's not what that means. Instead, what it is showing is that this trauma comes in layers, and that the building and building and building of these stress, this unresolved trauma, how it keeps progressing from adverse childhood experiences to reduced development within the schools or socially, how it can lead to social emotional impairment, how then it could lead to some risky health behavior, and then that in return leads to diseases, disability, social problems, and earlier death. Okay, so when I was sharing earlier about what it means to be trauma informed, I just wanted to go into that a little bit more in case there was some people who had questions about that. So really, as someone who's trauma informed, it's not our job to say cure everyone's trauma. Like as a speech language pathologist, I'm not qualified to do that. But being trauma informed, it just means that I have the ability and it's my goal to prevent further harm from existing. So I want to be able to have the skills to identify potentially adverse experiences that a child or family has been through, take into consideration what resources and realistic goals they may have, provide them with a safe relationship and a trusting relationship that if they would like to discuss situations and concerns with me, they can. I want to empower them to advocate for themselves, and I can also advocate for services for them if they don't feel comfortable to do so. And I overall just want to provide a buffer to prevent further harm from happening. And this doesn't only mean harm or trauma in like a physical sense or, um, you know, a verbal abuse or things like that. It goes further than that. So as an example, currently I work in a neonatal intensive care unit, a NICU in Manhattan. That's where I'm presenting from currently. And in the NICU, I always tell parents that, I know this was not your ideal delivery birthing plan. Something happens. Now the baby is here. It's my job that I take seriously of how can I help your infant in this less than ideal environment. I want parents to feel fully involved in their baby's care. I don't want them to feel only like visitors coming in. I want to get them involved from day one, so that way it's preventing further harm to the parent already feeling isolated and maybe having feelings that they failed their baby. And it's also preventing further harm to the infant, to my patient care as well, because if they were typically at home, they would be with their parent caregiver all the time. So instead of it taking from a focus to just doctors treating a patient or me treating a patient, I really try and get that family integrated model to provide that trauma buffer for both the parent and the infant. Okay, so now we're going to go into some details regarding the mealtime experience, because we're going to be talking about how trauma specifically relates to mealtime. And I do just want to say that I know I just provided an example regarding the neonatal intensive care unit, but for the purposes of this presentation, I'm going to specifically talk about eating as it relates to older children, such as toddlers, school-age kids, teenagers, etc. If you do have questions more about the infants, you can leave them in the Q&A section. And as Nancy said, I'm going to leave time at the end to answer any questions, so we can go over them then, okay? So mealtime experience. Overall, it's more than just a meal. It's more than just food, more than calories, more than just what goes in and what comes out. There actually was a pediatrician who said there are 4 things that are fed by you as a caregiver at a mealtime. The first is love, the second is care, the third is connection, and then the last is food. So when I'm asking parents questions or caregivers questions, family members questions about mealtime, I ask very specific questions, and I don't want to just know what they're having for breakfast, lunch, and dinner and the quantity that they're eating. I really care about the experience, because if we think about our own meal times and the social aspect of food and going out to eat and making memories, it's more than just sitting down and eating a meal. It's something that we can share our culture through. We can show as a form of self-expression through recipes. We can make new experiences and memories and traditions with family members. And it's something that really we can connect with by doing all together and sharing that undisrupted time. So it has actually been studied about the benefits of having a family mealtime. And when I'm talking about a family mealtime, I'm educating about sitting down for a meal. And this study wasn't just looking at families who were able to do this daily. This was seeing who participated in a family mealtime weekly. I believe it was about 2 to 3 times a week. And even at that frequency, the researchers saw benefits of having family meal times. So the 3 benefits that they found were children felt that they were able to handle stresses of daily life more easily. They also thought that they could communicate to others and speak up for themselves more confidently when they were engaging in a family mealtime. And lastly, they just felt more confident in general for their support system. So this is showing the benefits of having that mealtime together. I know that it's not always realistic for families to have meal times together, and I'm going to go into that on my next slide. when I was looking for research and articles, I actually found that because of COVID, families were having more meals together because during the pandemic, a lot more family members were working remotely, didn't have to travel, obviously not being able to go out to eat, more meals were being cooked at home. So there hasn't been an update in that regarding research for our current year, 2023. It'll probably come out by the end of the year or next, but I'm interested to see now that we're over the hump of COVID from where it was a few years ago, where those family mealtime stands currently. But as we know, it's not always easy to have this uninterrupted time for scheduled structured meal times. These are some challenges that I put together, but I'm sure you could probably think of more as well. So first, obviously, time constraints. Everyone's busy. If you have multiple children on varying schedules, that could also contribute to having unpredictability in your day and knowing, okay, at this specific time, everyone's going to be free to sit down. Also, if you have children maybe with special allergies or food sensitivities or intolerances, you may have to make separate meals for separate kids. And that could also pose as a challenge to having everyone eating the same thing at the same time. Some constraints, so the actual logistics and physical environment may prevent a family from sitting down together. So if in a kitchen, there's a table that only has 4 chairs, but the family has a family of 6, 7, 8, they might split up in you're going to eat at 6 and the rest of us are going to eat at 7 because of the logistical environment. And then lastly, but very important, food insecurity. So not knowing when your next meal is going to come, if you're going to have enough money to feed the whole family, etc., could also contribute to challenging aspects of a mealtime. I want to highlight this too. Food insecurity is trauma, right? Food insecurity might not be physically seen or known to others unless you're sharing that information and if you feel comfortable to, but not knowing when you're going to eat, if you have enough food to provide for your family, if you have enough food to allow that child to thrive and nourish and develop and gain weight, that is something that's traumatic and that can cause stress for not only you as a caregiver, but for the child as well. So this dietitian here recognized that food insecurity is considered trauma as well. Here are some statistics regarding food insecurity. So 1 in 5 children, according to the 2021 Bureau of Labor Statistics in America, is food insecure. So in terms of breakdown, and obviously this is going to be dependent per state and everything like that, but it did show that in general for the United States, that groceries are approximately $438 per month in the United States. And that's going to vary by how many people are in the household as well. But that, I think that was for an average of a family of 4. So that just highlights how much it is to afford groceries. And going here, it impacts the choices and what our children are eating. So there was a study done for feeding in infants and toddlers in 2018, and it looked at the meal habits of preschoolers. And it showed that 1 in 3 preschoolers didn't have a distinct vegetable portion within the past 24 hours that they were researching. And 1 in 4 preschoolers didn't have a distinct fruit portion. So this was partially because of food insecurity. It was also because of at preschool age, children are now being introduced to the school setting, which might not always be offering fruits and vegetables as part of their lunch or their snack or the cafeteria meals. Or it might be an option, but it might not be something that the children are required to eat. Also, in preschool, children are being fed by multiple different people. It's not only their family members. It could be teachers, it could be teaching assistants, it could be daycare providers. So being fed by a lot of different people can also impact how a children may choose if they want to eat something or not. And we know that preschoolers are particularly picky already, so they may not want to eat fruit and vegetables if they're outside of their typical environment and outside of being with someone they're comfortable with or that they know the routine for. Okay, now that we kind of introduced picky eating, let's go over what it really means to be a picky eater and some of those challenging behaviors that you may see as a parent or caregiver when you're trying to give your child a meal, or as a provider if you're taking notes and a history from a family and they're reporting certain concerns. Okay, so as a speech language pathologist, I just really wanted to highlight here the difference between a child who's considered a picky eater and someone who's considered a problem feeder. So there are a lot of different components here and bullet points, but I just want to highlight a few of them so you get the idea. So if you're asking a family about a mealtime, or if I'm asking a family, I'm going to ask them, what are the current foods that your child eats? And I want to know all of them. And if that's too broad of a question, I'll ask what they eat specifically out of fruits, vegetables, proteins, liquids, etc. So that way, then I can help prompt to make sure I'm getting as collective of an idea as I can. A picky eater in general is a toddler or a child who eats at least 30 foods. Someone who's a problem feeder eats less than 20 foods. Typically, when I'm working with children who are problem feeders, I'm thinking of patients who have been on the autism spectrum disorder and they're only eating 5 foods and that's it. Like chicken nuggets, Cheez-Its, goldfish, crackers, and Pringles. And that's all they're eating. Compared to a picky eater who has a wide variety, but they may just be hesitant to new foods or take breaks from foods and go back to it. But problem feeders are really the more severe feeders where they're not eating some kind of food from each food group, which could impact their nutrition. They always usually are eating different foods from the family or can't eat with the family because they're typically crying or tantruming when you even try and offer them a new food. And picky eaters, it's more considered a short-term phase of lasting less than 2 years. Usually when I hear it from parents, it's when they're getting around that 2 to 3 years old stage. And now all of a sudden they're becoming picky with what they eat, compared to problem feeders where you might think it's a stage, but then it ends up lasting for a really long time, over 2 years, and it doesn't seem to be getting better no matter what you're trying. So that's the difference between picky eating and problem feeding. Okay. So when I'm working with kids who have difficulties that I'm concerned more about their safety of their feeding, these are some red flags that I just wanted to share with you that you might either then refer to someone to evaluate their eating and swallowing, or that you might then probe and ask more questions about. So some feeding skill related problems. First, I have here that a child shouldn't be eating longer than 30 minutes. So what I mean by that is the active eating process should only last a half hour. If we think about when we go out to a restaurant, we know that's a social experience and we're having that last for an hour, 2 hours. We're not sitting there physically eating for more than 30 minutes, where they're socializing, where they're waiting for our food, where they're paying the bill, etc. If you have a child who is working on eating from his plate and it's taking longer than 30 minutes for him to chew the food, swallow the food, etc., that's considered a problem in terms of efficiency. For children, it's a workout for them to eat, for a baby to take a bottle, for a toddler to chew his food. So if they're engaging in that activity for longer than 30 minutes, they're actually expending more calories than they're taking in. So for me, if I hear parents being like, oh, it takes me an hour for him to finish his plate and he's not gaining weight, and I'm sitting there with him for this whole time, then I'm considering that a problem, because then I'm saying, of course, he's not gaining weight if he's spending all his energy trying to eat something that maybe he's not able to do yet. If you hear or see a child persistently gagging with foods, coughing or choking with foods, those are considered safety issues, especially if it happens seemingly routinely, like every day, every meal, not only on occasion. I would consider those red flags as well. If the parent or caregiver has anything that they report as concerns with swallowing, like, oh, I'm not sure if the child is swallowing it, it seems like he has a hard time doing it, then I would consider also referring out to a specialist for that. More obvious would be color changes when eating or drinking, such as turning pale or turning blue in color, could indicate that there's a lack of oxygen while eating. Holding food in mouth and where the food or solids seems to be like bulked up in the cheeks and the child isn't swallowing it and they're either spitting it out or you have to take it out of their mouth, I would have concerns about that as well. If you have a child who's toddler, preschool, school age, and they're still only eating puree foods and liquids and they can't seem to advance to solid or table food for any reason, that shows that they're not developing like their peers. And I would be interested to know then why they're not able to advance to those next stages. And the same thing goes for bottle feeding. So if a child is in school and they really can't seem to separate from their bottle when the rest of the peers are able to drink from sippy cups and straw cups and from an open cup, then I would want to know if that's a preference or if there's an actual anatomical, physiological reason why they can't progress. So besides if caregivers aren't this specific when you're reporting to them and asking them about meal times, they may discuss these general concerns regarding feeding and swallowing. So they might wonder if their child is eating enough, if their child is gaining weight because they have concerns about the child not eating a lot. Is my child eating enough variety of foods? I feel like he only eats the same 5 items and I don't know if it's enough for him. And are meal times always going to be this challenging? Is it something that's really just a phase and really developmental? Or is it something that I should seek help for or that will get better one day? Okay. And now, from a trauma perspective, trauma informed care lens, I'm looking at it, right, as it's more than the food. So, what is the child communicating through their behaviors during these challenging meal times? So, why are they throwing food? Why are they leaving the table? Why are they taking so long to eat? Why are they refusing? And maybe why are they either under eating or overeating? It may not be only a reason of they don't like the food, they're not interested in what you're serving them, they are just wanting to give a hard time and get your attention. It really could be something more systematic and more in terms of a trauma response. So we're going to go through that now. You all may have heard of these defensive strategies, how individuals react in the presence of a threat. The most commonly known are fighting and flighting, but there's also 2 other defensive strategies called freezing and fawning. So I'm just going to review each of these, and then on the next slide, we're going to be talking about how a child with each of these defensive strategies may act in a mealtime. So fighting in response to a threat, for those kinds of children, power and having control over the situation makes them feel safe. Flighting, which is fleeing the situation or the conflict or the threat, will help them by being constantly busy, and fleeing that inner pain that they may have for them creates safety. Freezing is actually when a child dissociates from the threat or what's currently happening in their environment. And that's a way for them to protect themselves by just disconnecting from what's happening. And then fawning, which is something that was newer to me when I entered the world of trauma and learning about it. Fawning is really interesting because it's actually when children are just compliant to whatever the caregiver wants, they give in to whatever the caregiver wants. And that's their way of feeling safe, that if I do what my mom wants, she'll continue to care for me and love me, and I'll feel safe. So those are the 4 categories: fighting, flighting, freezing, and fawn. They all present differently, but they all want to experience the same level of safety by the way that they're reacting. Okay, so here I have specific examples about how this can relate to food and eating. So in these yellow tabs, this is what maybe the caregiver will say, and then below is what the child may be thinking. Okay, so if we have a child whose defensive strategy is fighting, if a parent says, if you don't eat your fruit, you won't get dessert, the child may be thinking, this stuff must taste really bad if I need a reward to eat it. I don't want it. I'm going to fight. So then that child might respond by throwing the food, hitting, having a tantrum. That's their response of fighting. Next, if we look at the flight response where they flee, you need to eat at the table with your other siblings, might be what the caregiver says. The child then might think in their head, I was raised eating in my room alone. I'm not used to eating with other people. So that situation might make them uncomfortable, and they might flee by leaving the table and reverting back to their room. Next, freezing, when a child dissociates. If the caregiver says, it looks like you finished your plate. And freezing might be, when is the next time I'll be fed? Will they be mad if I ask for more food now? This could be a child who's freezing, who grew up in a food insecure household, who might be scared to ask for more food. And then lastly, a child who might have a fawn response. You would make my day if you ate that broccoli. And then the child might think, I should eat it so she continues to be happy with me. So that's when the child just wants to please the caregiver and give in to what they want, regardless of their own personal feelings, hunger cues, etc. So I just wanted to provide these examples and just to show you how this relates to the topic that we're discussing now. And again, that what is the child really communicating through their behaviors? It's not just to give their parent a hard time. Not always. It can really be in response to underlying trauma and childhood experiences that they've already experienced before coming to this new household. And then that's why they're reacting the way they do when they're provided with food or meals. Okay, so now we're up to our last section, which is some tips that I'm hoping to provide to you for promoting happy meal times. And actually at the end of this, I'm going to provide with a mock case study to really hopefully provide information of how to piece this all together. Okay, so the overall advice that I have for challenging meal times is to provide a responsive feeding approach. So we don't want to just create meal times and food as something that's transactional. Just, I give this to you, you eat it. We really want children to remember that it's more about the food. Food is something that helps fuels our body. It's a way for us to develop, grow, get stronger. It's a way that we connect with other peers and our family and our friends. And it's a way to satisfy our bodies when we're feeling hungry or thirsty. It's not something that we should just be doing because we're being asked to do it. We don't want to have, because all these children grow up to be teenagers, adults. And then if we think about our own relationship with feeding, we don't eat anymore to please other people. We're eating and we're choosing what we eat and how much we eat based on us following our cues of how hungry am I? What do I want to eat? Oh, I know I need to be eating proteins, fruits, and vegetables throughout my day. So now it's my choice to figure out how I'm going to do that. But children need to know from a young age that that's the relationship that they need to have with food. Not only I'm going to eat food that's green because I'm being asked for it, or because I'm going to get a prize or a reward or extra playtime, because that's really not setting the child up for a successful relationship with feeding as they grow older. We want to promote them to have some autonomy. Even at every age, there's something that they can do to participate and be active members of their mealtime. And we want to show that we respect them in terms of not forcing them to do something just for the purpose of doing it. So really, we're establishing that they can have trust in us and that they're safe with us and that we'll respect them. So that's overall what it means to have a responsive feeding strategy for children. So these are 4 main ideas that I came up with, and you don't need to implement all of them, obviously, within one meal time, or if you're thinking of maybe a child who's in your family who is picky or has challenging mealtime behaviors, starting off with even one of these components may be really helpful just to not overwhelm you or the child at, one time. But let's go over them. So the first is having personal preferences, suggestions for cuisine, getting each of the kids involved with that, asking what kind of foods are something that they would like, having a rotation between those foods, asking them what are some of their favorite foods so we know what are preferreds that maybe they look forward to or that are more preferred. And then if the child's older and willing to talk about it, asking them what were some of the mealtime practices that maybe they enjoyed or that they remember regarding their culture or their birth family, because that's something that maybe they want to incorporate into this new family and new home that would make them feel more comfortable. Offering mealtime expectations as a caregiver and as the feeder. So we decide what we're going to serve our children, but it's really up to the child about what they're going to eat and how much of it that they're going to eat. So I'm not promoting to, let the child just eat whatever they want, because I'm not saying, just give them M&Ms and if they only eat that and none of their protein, it's okay. I'm just saying that we need to have realistic expectations about portion sizes. It's okay if they don't finish everything that's on their meal, but if they try at least one of everything that's on their meal, that's more acceptable. Really promoting positive language around their body and food, and offering a variety of foods is really all that we can do. And how much of it is really going to be up to them. And that's something that's really challenging and something that's a new concept, I think, in our field. It's hard to kind of reduce the amount of control we have over that, but really by doing that, it is going to promote a healthy relationship as they get older. And modeling mealtime behaviors. Kids love seeing other children get rewarded for what they're doing. Tommy, I love how you're trying your broccoli. And then Susie's sitting across the table and then she's like, look, Mom, I'm trying it too. And then eating it. They thrive off of that. If everyone, okay, let's do a cheers with our broccoli. Okay, here we go. Cheers. And oh, I love how you put that between your teeth. It's okay if you spit it out. Maybe tomorrow when we have broccoli, you'll feel confident to swallow it like Tommy did. Really just promoting that positive language as well is going to be helpful for them. Giving them a routine and stability. So saying, okay, in our household, everyone has breakfast, everyone at home, everyone eats lunch at school, and then at dinner time, we're going to have a meal together at 7 o'clock, something so the children know what their day is going to look like and when they're going to be fed might give them that security and trust about feeding and meal times as well. If you have older children, getting them involved about setting up the table, if someone's with you food shopping, having them pick out certain foods that are on the list. And that could really promote having some independence and involvement and getting them excited about the meal as well. Lastly, I went into already ways about communication and providing a safe, trusting space, but also modeling appropriate ways to say no. So I'm sorry, Tommy, if you don't want that broccoli, it's not appropriate to throw it. We don't throw food here. If you don't want the broccoli, you have to put it on this plate. That way I know you don't want it. So really just establishing those boundaries and rules about appropriate ways to say no about a food, or if you're all done, that doesn't mean you dump the rest of your plate on the floor. All done means you can push your plate in front of you and lift your hands up. And I know that means that you're all done and you're no longer hungry. So really just incorporating preferences, expectations, a routine, and communication can help reshaping a mealtime for the family. Okay, so this is the case study example that I just want to go over quickly. So I made it up. The Smith family has 5 children at home. They're a blended family with some children who were fostered and others who were adopted. The children's ages vary between 2 years of age and 15 years of age. Mrs. Smith feels like she's constantly on the go, bringing children to their after-school activities, preparing everyone's favorite foods, which are usually different from each other, and making sure that everyone goes to bed on time. She reports 3 out of her 5 children are good eaters. However, she has the most difficulty with 13-year-old Sam and 3-year-old Grace. So let's learn more about Sam and Grace. So Sam, the 13-year-old, she joined the family within the past year. She comes from a home where her father died at 3 years of age in a tragic way, and she was present to experience it. Her mother was on drugs and worked as a sex worker. Sam felt that she raised her biological younger brother mostly on her own due to her parents, one passing away and then one frequently working and intoxicated. And then lastly, she engages in some risky behavior such as skipping class, smoking marijuana, expressing interest in sexual activity, and has a history of stealing. So that's Sam. And then Grace, our 3-year-old, she joins the family at birth. Her biological parents were teenagers. She does not have any biological siblings. She attends preschool 5 days a week, and she speaks in sentences. She has appropriate language that she can express her likes and dislikes at her age. So let's see how both of these children act at mealtime. So Sam, our 13-year-old, she has been known to steal food from grocery stores. She doesn't want to eat home-cooked meals. She declines eating with the rest of the family. She only wants to eat alone. She eats snacks frequently throughout the day, but not meals when offered. And she reports that she only wants pizza or Chick-fil-A. Those are the only, foods that she's really interested in when Miss Smith asks her what she wants to eat. Grace, our 3-year-old, she takes 1 hour to finish her meals. She coughs when she's offered food, solids that the rest of the family is eating. So the only solids that she can eat well are things like Cheez-Its, Puffs, and Goldfish. At pediatrician checkups, it's been reported that she has poor weight gain. And then at the table, she frequently will cry or swat her plate away when it's offered. So now let's figure out kind of why this might be happening. And then if you were in Mrs. Smith's position, how you can make mealtime happier for both of these children who have very different needs. So here's for Sam, if we take our 4 aspects that we were talking about preferences, expectations, routine, and communication. So now if we're asking her, she said that she only wants Chick-fil-A or pizza. If that's her personal preference, then since she's old enough, to be coming with you to food shopping, etc., say, okay, we could have pizza, but let's work together to make it homemade. What's the kind of pizza that you really like? Let's get those toppings from the store and let's get your siblings involved and we can all do this and make a pizza night together. For expectations, she's old enough that she can be accountable and, follow the expectations that you're setting for her. So if you're saying that everyone has to contribute to a mealtime in some way, whether that's her coming food shopping with you, setting the table, if that just means that, she has to attend the mealtime because it was said in the previous slides that she doesn't want to eat at the rest of the table. Even if she just sits to participate in the social aspect, that could be an expectation. And if she feels more comfortable eating in the room, that might be something that you would start out with. And again, expectations are that you're going to be offered nutritionally diverse food. So even if we're having pizza, we're going to have a side of vegetables, we're going to have our vegetables on our pizza, etc. We still need to incorporate our food groups into our meal. For Sam, it seems like she had a history of stealing, and I don't know why that is, but maybe instead when going food shopping together, giving her an allocated, say, $15 that is going to be enough for her to buy the groceries for the pizza. And then that way she feels that she has independence in purchasing that, and teaching her, appropriate ways that we can get food, then can help with that. Maybe offering special days for getting takeout for her Chick-fil-A that she would like. So making that, maybe that's going to be our special treat for Fridays or Saturdays. And then if she's someone who is frequently snacking throughout the day, again, reminding her of the routine of, okay, remember for everyone to be hungry and not snack anytime before 6 p.m. because I'm going to be serving dinner at 7 p.m. And then lastly, communication wise, asking her maybe what meal times looked like with her brother, because it seems like she was the primary caregiver for him. She was probably the one serving the meals, or at least giving them to him, and what would make her more comfortable to participate in meals and join the rest of the family doing that. So that's my propositions for Sam. And then for our toddler, Grace, I have more concerns regarding the actual skill level that she might have regarding her solid food, because it said that she was coughing, that she was taking an hour to eat meals, she wasn't gaining weight. So for her tantruming, her pushing away the food might come more from a place of safety because she can't actually handle the food that she's being given. So here I have giving her an option between two of foods that she can actually do from like a skill perspective. So for expectations, if you want her to have foods that are nutritionally diverse, like fruits and veggies, give them to her in pouches, smoothies, fruit flavored yogurt, Go-Gurt, just something that it seems like maybe she's able to do more instead of the actual solids. Always offer a variety on her plate without the expectation that she's going to eat everything. And then kind of like what I was showing before of like that positive modeling of trying, tasting foods, everyone doing it together would be something that maybe we can also model for her. Since she's at preschool, we know that she's going to be offered lunch there and probably a snack. Maybe inquiring with the school more to see if she's eating only for a half hour, seeing how they're feeding her there. Is it at the table with the rest of the kids, or is she in a high chair? What's the expectations? And then for communication, 3-year-olds can still express themselves, but I would just use some clear communication, like time to eat, ready for fruit, small piece of this. And if she starts acting up, like hitting, tantruming, crying, asking her, are you all done with? Are you hungry? Do you need me to blank? And then she can respond with either yes or no. So I know it's a lot of information and it might seem impossible right now to change, but I do want to give you guys the confidence and also information that change isn't linear. You're going to have some uphills, then some setbacks, and it's going to get kind of messy, because if you're introducing these new concepts that have never been part of your family or mealtime before, you're going to get some pushback before making some success. But the slow, intentional, and consistent changes will lead to permanent changes over time. So hopefully you will have a happy mealtime by the end. Here are just some references for the diagrams and statistics I was using throughout. And now we have time for a few questions. This is my personal email in case we run out of time and you want to message me directly as well. Thank you.